First, I'll say my name is Harry Hockheiser. I'm the director of the MIDAS Center. I also want to welcome on Praveen Kumar here, who is a co-investigator and colleague working at the MIDAS Coordination Center. And our speaker, Dr. Nasif Hossain. Dr. Hossain is an environmental epidemiologist whose research examines how climate variability influences the transmission of infectious diseases, integrating statistical modeling, epidemiology, and climate science to inform data-driven public health strategies. Currently, his research focuses on how environmental conditions induce child diarrheal pathogens and infections in low and middle income countries. The talk is going to be about the spatiotemporal variation in Campylobacter infection risk in childhood. And as I was saying before folks joined in, I think it's nice to hear something that is about some concerns we usually don't think of here from our very US-centered focus. So Dr. Hossain, I'll hand it over to you, and I'm looking forward to your talk.
Thank you, Harry, for nice introduction. May I share my screen? Thank you. Is my screen visible?
Yes, it is. We're seeing your full PowerPoint window without the, so you might as well go into presentation mode.
How about now?
You're all set. Go right ahead.
Thank you so much. My name is MD Nasif Hossain. Currently, I'm working as a postdoctoral research associate at Environmental Institute and University of Virginia. Today, I'm going to present the spatiotemporal variation in risk of Campylobacter infection in childhood, a global risks mapping and prediction model using individual participant data. Oil Campylobacter is a bacterium primarily caused by Campylobacter jejuni, is one of the most common causes of diarrheal illness globally. Campylobacter is a zoonotic pathogen spread through the human-animal environment interaction with surface, water, soil, and crop acting as a reservoirs, especially where waste management is poor. Studies have shown that weather pattern influence the seasonal and geographic distribution of Campylobacter infection. Accurately estimating the burden of Campylobacter infection is essential for identifying high-risk population and directing effective intervention. The objective of this study is to develop a risk mapping and prediction model of Campylobacter infection using individual participant data compiled by the Planetary Child Health Enteric Observatory. Model the spatiotemporal variation in childhood Campylobacter infection using covariates like 3 age group, 0 to 11 month, 12 to 23 month, 24 to 59 months. Here we stratified 4 syndromic strata like asymptomatic, community detected diarrhea, medically attended diarrhea inpatient and outpatient. We produced high resolution map of predicted Campylobacter prevalence, gain insight into drivers of transmission risk and seasonality. The hypothesis of this study is the probability of Campylobacter infection in a given location varies day by day as a function of antecedent weather condition. In the right-hand side, the conceptual diagram of the relationship between physical process and enteric infectious risk. There have 3 most pathways for diarrheal infection. Its first one is airborne pathogen through the temperature, pressure, humidity. Second one is survival on soil and surface. And the last one is waterborne pathogen dispersal. Method, this is an individual participant data meta-analysis of the study. We have collected multiple pathogens tested by a PCR diagnostic method. The studies is carried out in low and middle income countries. This time we have considered only under 5 years as subjects. We identified the studies through the literature review and professional network and contracted through the data access request. We contact to the investigator. We set up a data sharing agreement. We have the data management plan like data stored in a secure place. Study specific data set combined into a central database with a standardized format. So far, we have collected 30 studies carried out in 26 countries. Household and subject level data come from survey data source like demographic health survey, cluster survey, and multiple health survey. In the right-hand side, the number of sample and study design is showing in this map. Number of nationally representative household survey by country for including low and middle income countries showing in this map. The small countries represented by circles. Data and process flows. Transfer study specific database covered by data use agreement. We are applying Bayesian generalized multivariate modeling approach and daily prediction of infectious disease risk. We are collecting the household and subject level data. This is one of the example of the prevalence of finished floor in low and middle income countries. Interpolation based on the household survey and survey data and environmental covariates. We are also collecting static environmental variable like enhanced vegetation index in low and middle income countries showing in this map. We are collecting time varying hydrometeorological variable through the ERA5 land dataset. This is the example for soil moisture. The table is showing the time varying hydrometeorological variable in ERA5 land included in the Planio database. This is the list of full list of ERA5 land variable that we are considering. Lag and aggregation of ERA5 land variables. We aggregate average or total of ERA5 land variables over a lag windows of exposure relative to the date of sample collection to account for incubation period, which is not fully characterized, varied slightly by pathogen, but is mostly short within 7 days. T0 is representative the date of sample collection, and this is the windows of lag exposure, and we are expecting this is the incubation period. statistical analysis, we are applying generalized additive model, GAM, adjusting for control variable, participant level variables, household level variable, and static environmental variables. We have adjusted the spline term of hydrometeorological variable using natural cubic spline function with a mostly degrees of freedom is 4. Model result used to make a separate prediction by syndrome and results. The table 2 is representing the number and percentage of stool sample with available Campylobacter positivity status used in this analysis by child age and diarrhea symptoms. In the diarrheal symptom, we have found the medically attended diarrhea is most percentage is 38%. This is the result from full model of generalized additive model. This is age and syndrome status result. We found a significant positive odd ratios for age 12 to 23 months and age 24 to 59 months. And medically detected outpatient diarrhea as odd ratio is more than 1, and it's positively increasing the risk of Campylobacter infection for medically detected diarrhea outpatient. Here we found some important factor that influencing the increase of probability of Campylobacter infection. Unimproved water, livestock like ruminant, pigs, and poultry. On the other hand side, we found some protective factor that is protective for Campylobacter infection, like finished floor, education level, and footprint. This is the result of hydrometeorological variable that is some of the hydrometeorological variable increase the Campylobacter infection, and some of the hydrometeorological variable decreasing with increase of hydrometeorological variable. For example, when temperature is increasing, Campylobacter is decreasing. Like low temperature is increasing the Campylobacter, whereas surface pressure is, we found that like a U shape, like extreme surface pressure increasing the Campylobacter infection. On the other hand, solar radiation, wind speed, and standardized precipitation index increasing the Campylobacter infection. This is our pipeline analysis. We have also comparing our analysis like rotavirus and Campylobacter comparison. This is our ongoing result, just for showing like some of the part is reverse result we found for Campylobacter versus rotavirus. Like here we found the reverse result for relative humidities, surface pressure, and wind speed. But this result is not has been complete. When we'll complete, we'll share that. Previously, we found our Campylobacter analysis result that has been published in GeoHealth. This result is consistent in our recent finding. This is the prediction map of Shigella analysis. Now we are producing the probability of infection in the prediction map. We are expecting the result will be look like the similar. In the parallelly, we are running another project. The name is Spring Project. Is an interdisciplinary collaborating, bringing together experts from climate, environment, health, and social science with communities, industry, public authorities, and policymakers. The aim to inform key climate, environmental, and health adaptation policies to support and prepare citizen communities and government by better measuring and impact of future climate shocks on the burden of waterborne diarrheal disease. Our approach for 4 pathogen monitored and studies. The first one is rotavirus, Campylobacter, Cryptosporidium, and Giardia. Conclusion so far, this is not our final conclusion, but what we have found, this is the Campylobacter infection risk is highest among older children and those with medically detected diarrhea, especially those seeking outpatient care. Environmental and household factors like crowding, poor sanitation, and proximity of livestock significantly increase the odds of infection. Protective factors including breastfeeding, higher education, improved sanitation, and finished fuel. Integrated multi-sectoral strategies combining wash improvement, nutritional support, and climate-resilient infrastructure are essential to reduce the Campylobacter infection in children. Dissemination and interactive web-based dashboard, data access, and visualization system switch to interactive map to collect and disseminate the data produced, and international consortium of investigation global network of collaborative research network. This is our current dashboard. You can, if you are interested, you can scan the QR code and see the more details for other pathogens. Thank you so much for our collaborators from University of Virginia and Johns Hopkins University, and we are also very grateful to our funding who have funded for this project. Thank you so much.
Great, thank you, Dr. Hossain. We have a question in the Q&A. And the question here is, how has the probability of risk been calculated? Does it use a logistic regression?
Yes, it is logistic regression.
Great, thank you. If you have other questions, please put them in the chat or raise your hand. I will just ask a question here about some of your risk factors. Seems like a lot of those risk factors are likely to be highly correlated.
Yeah.
And so wondering, is it useful to either think of this in terms of you know, the simple thing to do would be to eliminate or to reduce some of the highly correlated features. Another thing to do, which I have some hypotheses about, would be to look at this almost in terms of a causal analysis and try to figure causal relationships between these things, because I mean, it seems pretty clear that the root cause of a lot of these factors are going to be socioeconomic, right? So
Right.
Have you considered any analyses like that?
Yeah, we have checked variance inflation factor like the multiple collinearity, and we have found the very big variance inflation factor. And on the other hand side, we have checked the semi-variogram for to check whether they have a autocorrelation or not, but we haven't found that type of too much autocorrelation.
Thank you. So another question here, can you highlight some of the more surprising findings? It seems that the association with symptom severity and temperature are not what we might expect a priori.
Yes, we expect like temperature should increase the risk of Campylobacter infection, but here we found the reverse association. This is the interesting result.
So do you have any explanation for that or any theories about it?
Mostly, like we know from our literature review, like bacterial pathogen mostly increase with temperature, but here it's decreasing. It could be possible like under detection. Like it could be one of the possible explanation, like under detection or few sample size from some specific location.
Which actually raises sort of another question that I was curious about in terms of your various data sources in your early slides. Do you have any feeling for the sort of the accuracy of and the completeness of any of these data sources? And I assume that would differ by location, right?
Right. Well, I could give one of the example like global enteric multi-center study. You may know that this is one of the big contribution of the studies. They maintain the oil standard data processing flow. So we believe that the data collection process was correct from that side. As we have collected the data from them, like Mali study also participate in these studies, and we believe that they have maintained the gold standard method for data collection, processing, and everything. Just a moment, I'm coming back. Yeah.
But I also saw in your workflow, for example, you mentioned imputation at one point. Could you talk a little bit about where imputation comes into this modeling?
Imputation, you mean?
There was a step in your workflow that involved data imputation, wasn't there?
Oh, right. It's imputation, like it's mostly for survey data set. Like some of the site or individual, the data is not available. So we have interpolate for them for that specific individual. Take the average. Somewhere we have take the average representative part from the demographic health survey.
Sorry about that. Do we have any other questions for Dr. Hossain? I'll throw that out one more than just myself, but you mentioned this partnership, excuse me, towards the end of the talk, and it would seem that a lot of that was about implementing responses. So can you talk a little bit about what you think are the non-obvious ways that these models can contribute to policy choices? Because I guess I just think that I would imagine that, say, cleaner water and better sanitation are probably fairly obvious goals for a bunch of other reasons beyond Campylobacteria. Are there things that are non-obvious that go beyond those measures that have come up out of this work?
Well, yeah, I could explain something. Yes, water sanitation and hygiene is a big contributor for increasing Campylobacter or any type of bacterial infection. Here we found like unimproved water is increasing the risk of Campylobacter infection.
Mhm.
On the other hand, like finished floor is kind of protecting the Campylobacter infection. Livestock is contributing the increasing of Campylobacter infection too. Like in the background section, I may be mentioning one of the things like here, the Campylobacter infection is a human-animal environmental interaction. So we found the livestock is contributing positively increasing Campylobacter infection.
Right, and I guess that's what I was thinking in terms of policy implications, that getting clean water to people is probably a high priority for a bunch of reasons. It may be fairly difficult, but I'm wondering if your results might suggest, for example, that finding ways to improve livestock management and practices around that might have a big impact at a relatively lower cost. Would be an interesting question to ask.
Yes, I agree with you. Definitely, we have to think about that.
Okay, we have another question here. It says median is better as it is not affected by outliers when you interpolating the missing data. What do you feel about this? So
Of course.
interpolating based on the median as opposed to the mean, I guess.
Yes, thank you so much for your suggestion. Definitely, we'll try your suggestion in our studies.
Okay, any further questions? All right, well, hearing none, I think maybe we can just thank you for the talk. Interesting work. And as I said, fascinating to hear about some things that we usually don't hear about when we're talking about Northern Hemisphere infectious disease. So appreciate you for bringing up a topic that isn't necessarily on our usual list. So thank you again. Reminder to anybody who might be on the list call here who's in the DC area, the MIDAS meeting is Monday through Wednesday next week. So if you can come up to Bethesda and join us, we'd love to see you there. And if not, maybe we'll just see you next month at the next MIDAS webinar. But in the meantime, thanks and have a great day.